we'll be talking about a new therapy we're doing at the hospital. We started doing it for people that were going to get knee replacements. To do it ahead of time, to try to help them with pain after the surgery, make therapy easier for them, and use less medication for pain. That's what the idea was there, okay? All right. We got something showing up there. If I use this, can you see that? Everybody see that green dot?
Yeah.
Okay, good. Yeah. Yes, thank you. All right. We're going to get to that, about the new treatment we're doing, but I figured let's talk about knee arthritis in general, okay? Talk about the relevant anatomy of the knee, what arthritis is. I know many people already know what knee arthritis is. We'll talk about what you might experience, who gets it, and how you diagnose it. Can everybody see this okay? Mm-hmm. Okay. Treatments, including changes to what you do in your life. Different modalities, and I'll talk about what that is, including bracing. Aquatic and physical therapy. Alternative treatment options. Medications. Injections. And then lastly, cryotherapy, the new treatment that we're doing here at the hospital. Okay? That's where we're going today. The knee joint. It's the largest synovial joint in the body. All synovial joint means it's connecting bones with a fiber capsule. That's what that is. It's the largest one in the body. It's made of 3 bones. You have this bone, which is the thigh bone. This is the leg bone. It's called the tibia. And then what's not pictured in this here is a patella. It shows up right about here. Okay? There's another leg bone down here called the fibula, but it's not involved in the knee joint. Okay? You have cartilage, which is on the ends of the bones to where they meet. Very smooth, allows for smooth movements in the knee, okay? That's what's shown in white here. You have ligaments, which aren't pictured here, but they are connective tissues that go from bone to bone. They provide stability in the knee. You have something called a synovial membrane, which is shown here in gray, all through here, okay? And basically it's a capsule which produces fluid for the joint. Okay? It helps keep the joint lubricated so it can move easily. And it also gives nutrients to the cartilage, the white stuff here. Okay? The knee joint is very important because it needs to be able to support 3 to 5 times the body weight. So a lot of pressure is on the knees. Arthritis. All it means, it's a great term for inflammation in the joints. Other names you might hear: degenerative joint disease, wear and tear arthritis, or that Uncle Arthur that nobody likes. It's the leading cause of disability in the world. It develops slowly over 10 to 15 years and interferes with daily life and activities. Very common. 31 million Americans have arthritis in general, not just knee arthritis. 14 million Americans have knee arthritis that produces symptoms. Okay? If everybody took x-rays, everybody, there are going to be people that have changes on their x-rays that show arthritis, but not everybody has symptoms of arthritis. So there's 14 million people that have symptoms because of knee arthritis. 13% of women and 10% men age 60 or older have knee arthritis that causes symptoms. Lifetime prevalence of knee arthritis that causes pain, meaning out of everybody, 45% of people are going to have some knee arthritis at some point that causes problems. Okay? Prevalence increases with each decade of life. So the older we get, the more common it is. Okay? So here's looking at what arthritis might look like. You have a nice looking cartilage here shown in white. Arthritis is a breakdown in the cartilage shown over here in red. And there's cracks shown in the cartilage. The cartilage wears out, you get inflammation in the joint. This reduces the lubrication and cushioning in the joint. Something called hyaluronic acid is very important in this. And I'll talk more about that. That's going to be important for one of the treatments that we use. With more advanced arthritis, the knee deforms and becomes unstable, meaning you can't support the weight when you're doing things like going up steps or other activities. The knee becomes painful, swollen, stiff. Okay? Here's what arthritis feels like. You get pain around the joint. It can be a dull or sharp pain. It can range from mild to severe pain. And it can have a sudden, it can come on suddenly. Some people think arthritis has to come on slowly, but you can have flares of arthritis. So you can get a sudden flare of pain, and that can be arthritis. You can have decreased range of motion in the knee, grinding, popping, locking sensations in the knee, muscle weakness around the knee, which gives a feeling of giving away of the knee, and swelling. So what does it do to our daily lives? It makes it difficult for walking, climbing stairs, doing household activities. You can get pain and stiffness, especially in the morning, typically up to about half an hour or so. There are other kinds of arthritis that give longer morning stiffness. This tends to be about half an hour or so. It doesn't have to be exactly, but around there. It can be after sitting or after prolonged rest. It can happen. And the pain gets flared with vigorous activity. More advanced arthritis, you can have more frequent pain, pain at rest, or nighttime pain. Any questions so far? Risk factors. Who gets knee arthritis? These can be divided into things we can't change, which will be on this side, and things that we can change, which will be over here. Everybody gets older, so I can't really change that, right? So that's one thing. Females tend to get more knee arthritis. Genetics, so our makeup of when we're born. How the knee is aligned, how the bones stack on one another. Any injury to the knee that's happened before. So you can't go back in time and change that, right? That's something that just happens. Here are things that we can change. Our weight. That's been strongly shown that having less weight on the knee joint gives you less risk of arthritis. Poor muscle strength, especially around the knee. Smoking does not help with, that's a risk factor to get arthritis. Any lack of activity. So our joints they're built for movement. So without that movement, then you get a higher risk of arthritis. And then heavy physical labor jobs like that involve kneeling, squatting, things like that. Okay? I highlighted two of these, advancing age and weight. These are the strongest in each category for the risk of getting arthritis. So people, as we get older, the risk is there, and having too much weight on the knee, that's also a very strong risk for knee arthritis. How do we diagnose it? You go into a doctor's office and you talk about what's going on. So that's the history. The examination, the doctor should look at your knee. Look for signs of inflammation, which is swelling, redness, warmth, and if the knee joint wants to form. Here's a pretty dramatic picture of swelling in the knee. So here, this is the right knee over here, this is the left knee over here. Here you can see the outlines of the bones around the knee. Here you kind of lose that, right? There's a lot of fluid on this knee. So that's a pretty exaggerated look at what swelling of the knee looks like. You can get joint deformity with worsening arthritis. And then X-ray imaging is important to diagnose arthritis and staging how bad it is. Then it's important for your doctor or provider, the person that you talk to rule out other causes of knee pain. Okay, let's see what the X-rays look like with arthritis. So again, top here is the thigh bone, down here is the tibia, the Patella is, you just see a faint outline of it here. But the patella is the third bone. That's the kneecap on top of your knee, right? Things I look for with an x-ray is the spacing between the bones. X-rays are great at seeing bone. They're not real great at seeing softer tissues like cartilage. Meniscus is like the cushions between the bones. That's why there's a space between the bones, because that's the bones are sitting on the meniscus. Okay? So I'm looking at the space between the bone. This is the outside of the knee. The reason I can tell that is because the fibula is on the outside of the knee. If you feel on the outside of your knee, on the side, you can feel the bone, and that's right here. Okay? And this is the inside part of your knee. So this is mild arthritis. What I'm looking at is the spacing between the bones. Can you see the spacing between there? The darkness? And compare it to this side. You see how it's a little bit thinner there? On the inside of the knee? So this person has mild arthritis on the inside part of the knee. Here's a little more advanced arthritis. Same idea. Outside of the knee, inside of the knee. Spacing, it looks good here. This is normal on this side. See how much thinner it is on the inside? Okay, other things I'm starting to see here. There's an arrow pointing to this little bone pushing off here. This is called an osteophyte. It's a growth of bone off of the main source of bone. That's another sign of arthritis. Okay? So I'm looking at the spacing between the bones and these little extra pieces of bone that are growing off. Those are signs of arthritis. Let's look at the next one. This is more moderate level arthritis. Here, the spacing's good right here, but it's a little bit thin in here. And then the thinness continues on the inside part of the knee. Then you see this piece of bone pushing out there? That's a larger osteophyte. Another sign of arthritis. And we're starting to see a little more brightness on the edges of the bone. That's because the bone's starting to hit each other a little bit. And you get more compacted bone in that area. Okay? And then this is severe arthritis. Okay? When a doctor or a provider says bone on bone, they're talking about this. See that? The joint, the space between the bones is gone. The bones are touching each other at this point. The cartilage is gone. You can see the spacing looks okay here. There's a bone spur right here. You have the loss of the joint space here. You can even see the thigh bone is moving that way compared to this bone. You see that? How it's shifting a little bit? This bone compared to this bone. That's more advanced arthritis, and you get some deformity, or the knee gets deformed because of the arthritis. Any questions so far? Okay. Other studies we might get, CT scans, MRIs. These look at the bones or soft tissues around the joint. These are used more to look for other causes of knee pain. And you can get blood tests, again, to look for other causes of knee pain. Treatments. So the goals of treatment: reduce pain, improve how your joint moves, improve function and quality of life. Okay, that's the goals of this. First thing, lifestyle modifications. You want to switch from more high-intensity exercises, if that's something that's part of your life, to where, like running or jumping exercises, to more less impact exercises like biking or stationary biking or swimming. You want to minimize activities that aggravate the condition. So if climbing stairs is something that aggravates the pain, you want to minimize that as much as possible. Obviously, it's tough if you have a lot of stairs in your house, you can't move, things like that. But if you have an elevator available or other ways to get around, then you want to listen to your body. I tell my patients that a lot. If something's hurting you, there's a reason it's hurting. So you want to try to change what you're doing, if you can, to avoid those activities. You don't want to stop doing everything, you just want to change what you're doing sometimes. Weight loss reduces the risk of knee arthritis. Every 2 pounds weight loss reduces the risk of knee arthritis by 10%. If you have known arthritis of the knee, it makes it less likely if you lose weight, that'll get worse. So you have less symptoms and improved function with weight loss. 1 pound of weight loss takes 2 to 4 pounds of extra pressure off the knees. Weight production of 10% improves function by 28%. So a huge difference, right? This can be difficult, as we all know. Modalities. You have icing, heating to the knee, using devices to help us walk, like a cane to help take the pressure off the knee. Different inserts or things we can do at the foot level. So this is something called a lateral wedge. Lateral just means outside. So you can see there's a higher height in the wedge out here compared to in here. What that does, it takes the pressure off the inside part of the knee. So someone with arthritis of the knee on the inside part, this helps take the pressure off there. Sleeves around the knee mostly provide a small amount of compression to the knee, give some warmth to the knee. So that can help people feel better. Bracing, so this actually helps provide stability to the knee, but the problem with it is it's pretty bulky, right? And if you have knee arthritis, a lot of times you get swelling and it's difficult for something like this to stay on. It does not mean you can't try it, it's just that's some of the problems with it. And then this is called TENS treatment, transcutaneous electrical nerve stimulation. This is these pads that provide a light amount of electricity to the muscles around the knee and can get pain relief. Aquatic therapy. There's less joint impact, can be used as a bridge to more land-based therapy. Physical therapy, the more traditional, what we think of, they focus on aerobic walking, leg muscle strengthening, resistance exercises, that stimulation we talked about before, TENS treatment, and joint range of motion. Alternative treatments, these are more Eastern philosophy type treatments. Evidence is okay for these. Some people get great relief with this, sometimes it's worth a try. Acupuncture focuses on the energy centers of our body, and Tai Chi is a form of martial arts that focuses on slow movements of the joints. Topical medications can be used. Who's heard of some of these before? We have BioFreeze, Aspercreme, Caspacin, Joint Flex, Blue Emu, Salon and then prescription grade Pensed and Voltaren. Did I miss any? Yeah. A lot of options, right? These are all creams, things you can rub on the area. And then these are good joints to try this on because there's not much tissue in the way of getting down to where the things that cause pain. Medications. Tylenol is the first line treatment as far as medication you take by mouth. The reason is there's not too much risk with taking it. Every medication you take by mouth has some level of risk. This has the least amount of risk. The problem is it doesn't work quite as good as the other treatments, right? So you have something like Aleve or other anti-inflammatory drugs. These help actually to decrease inflammation. And they're okay for short-term use. It's just not great for long-term use. There's more and more evidence out there that says long-term use of anti-inflammatories can affect the belly, the kidneys, and the heart. Other medications like this would be like Aleve, meloxicam, Mobic, diclofenac. There's a whole variety of these type of medications, all anti-inflammatory medications. Glucosamine chondroitin, some people might take this. This was more popularly used maybe 10, 15 years ago, but still used today. These are components of the cartilage in our knees. It's a pill you take. And the thought is if you're taking more of these components that are important for the cartilage in the knee, that maybe you can help build it up. Fortunately, the evidence hasn't really been that great for it. The most effect we've seen about in studies, clinical studies, is about 10% change. So a small amount of effect. Opiates, I'm sure many of us have heard, someone in our family has been affected by opiates. There's a big push nationally right now to try to reduce the risk of opiates for many reasons. These were more used in the past. There's a strong push to get away from this at this point due to the many risks of taking opiates long term. Knee injections. can be steroid injections. That's one option. This acts as a very strong anti-inflammatory, great for short-term pain relief. Repeated injections may break down the cartilage. So we know breaking down the cartilage leads to further arthritis. Studies aren't, there's some showing break down the cartilage, some are not. So it's not clear right now how much, if steroids can break down the joints further. What they do though are great for short-term pain relief when need be. Something called viscosupplementation or hyaluronic acid. This is the rooster comb shots you may have heard of. Originally taken from rooster combs, and it's a cartilage replacement injected back into the knee. Something like called Euflexa or Synvis. These are the brand names of these. This helps restore the hyaluronic acid levels in the joint, helps lubricate and help with shock absorbing in the knee, works as an anti-inflammatory, calming down inflammation in the knee, and allows for cartilage regeneration. The peak effect of this is in the 5 to 13 week range. So we're getting up towards 3 months. It's a longer peak range than a steroid injection. Steroid injection is more in the 2 to 3 week range. So much shorter for the steroid injection. Some newer type of injections is something called platelet-rich plasma. This is in the stem cell type treatments. It's taking the healing factors from your own blood and using that to inject into the joint. This stimulates repair of damaged cartilage. It's anti-inflammatory. The problem is it's not covered by insurance, so that's limiting for many of us. Although there's some work, especially by Highmark, from what I hear, they're working on trying to get this approved, so this can be a nice option in the future. The evidence for it is mixed. It's still early. There's still a lot of studies going on with this. The higher quality studies have shown benefit to using this. The nice thing about this is it's from your own blood. It's your own healing factors that you concentrate and you can inject into the area. So the side effects of it are minimal. Here's how it works. You draw blood, collect it, and inject it into a machine that spins the blood at extremely high rates in the range of 3,000 times per minute. You split the blood out. So here's the red blood cells shown here in the dark, and you have plasma shown here. Then you take the top layer off, and that's the platelet-rich plasma, what you inject back into the knee. That has healing factors in it from your own blood. Any questions?
What about getting back to the ESC?
Okay. As far as injections go, they can be landmark guided injections, meaning the person that's giving the injection feels around the landmarks of the knee, where the bones are in an area, and you inject, which is good. You get 81% accuracy with that. So basically 4 to 5 times, get it into the spot you're looking for, which is in the knee joint. There are other ways to give injections. This is an ultrasound-guided injection. See this thing right here? That's called an ultrasound probe. You might hear ultrasound, the first thing you might think of is when someone's looking at their baby to see how the health is of the baby, see if it's a boy or a girl, something like that. And there's been more and more use of ultrasound for the arms, for muscles, tendons, other joints, things like that in the body. It's not just for babies anymore. It's becoming much more widely used for areas of pain in general, including the knee. So here's a front view of the injection given from the side here. Here's looking down this way, so the injection given this way. Here's what it might look like on ultrasound. You have a tendon here, that's this thing right here. You have the bone, which is this white line at the bottom. This is a fat pad in the knee, which is a normal thing. Then this dark stuff right here is fluid in the knee. Fluid in the knee is actually in the joint. So you can see this needle coming right across right in the fluid, which is in the joint. So what this does is it increases the accuracy of injections up to 97% by having this visualization of the needle going in. So there's ways to make it much more accurate. If it's a more accurate injection, there's a better chance it works. What I'm guessing everybody mostly came to hear about, so this is the cryoneurolysis. This is the new treatment being done here at Monongahela Hospital. We're the only one in the region doing it. So cryotherapy. All that means is local or general application of low temperatures for medical therapy. Okay? Cold blocks the nerve conduction of pain signals to the brain. Similar to the effect of a numbing medication given to somebody. It blocks the pain signals. When applied to nerves, it's called cryoneurolysis. Cold to the nerve, that's all it means. Okay? Here's what the device looks like. You have a station where it gets charged. This is the device that's used for treatment. In the top of it, up here, is this cartridge. It has liquid nitrous oxide that runs down through here, and it goes to this treatment tip, which is right here, and goes all the way down to these small needles where the treatment is delivered. Okay? Another look at it. So here's how big it is compared to somebody's hand. At the top of it is the nitrous oxide, the liquid nitrous oxide. It runs through some control valves, other things in here. It freezes these needle tips where the treatment's given, and then it becomes a gas and is ejected out of the device. So nothing's actually injected with this. All it's doing is making the needle tips extremely cold. Okay? Here's what it might look like underneath the skin. This is before treatment. See the needles right here, 3 of them, right here, underneath this model of skin. And then you have treatment right here. See this kind of white oval right here? The company calls it an ice ball. So that's an ice ball underneath the skin where the nerve gets treated. Any questions so far?
How are you?
Yeah. Oh, yeah. We'll get to that in a second. Sure. Huh?
How long does it last?
Get to that too. All right. So you can use ultrasound for this. So shown here in green, this green dotted line underneath the skin is a nerve that we're looking to treat. You have the device with the 3 needles, and that's the ice ball shown here. They changed the color to like a bluish gray or whatever this is. And so the idea is to put this ice ball right on top of that nerve. Okay? These are the nerves that are treated. To answer one of the questions. This is a picture of the end of the thigh, kneecap being down here. Okay? Does that orient everybody? So this treatment from A to B right here is above the knee. So that's one treatment line across the top of the knee, like in the thigh area. Okay? One treatment line. That's for those that want to know, anterior femoral cutaneous nerve. Okay? That provides sensation to the thigh all the way down to the top of the kneecap. Then you have the infrapatellar saphenous nerve. Kneecap's right here in this picture. Okay, so this is below the knee, on the inside part of the knee. So here's the treatment line from A to B, right here. Inside of the knee, running from top to bottom. That's the second treatment line. This nerve wraps around here and has 2 branches, one running right here and one running all the way down here. You see these nerves run across. So just because you're treating them on the inside part of the knee is trying to cause pain relief even on the outside of the knee because these nerves wrap around like this. Okay? So this gives the sensation to the knee, below the knee, and even to the bottom of the joint. This is how it's done. Treatment lines are drawn in the area based off landmarks in the knee. Ultrasound can be used to identify the nerves. We recently just switched over to using ultrasound, which makes the treatment much quicker and easier for patients in general. Can give numbing medication beforehand to the area. The device is inserted. So here's the treatment lines drawn here. Here's the device working, okay, underneath the skin there. And then a treatment cycle happens. A treatment cycle where that ice ball's formed takes about 45 seconds or so. And then you move to the next spot, and you treat the nerves in each location. A little more about how this works. This is a nerve. It's wrapped in this green tissue. It's a connective tissue. The base unit of a nerve is called an axon. The signal from that nerve travels down the axon. This is yellow thing shown here. It's shown in all these circles. You see that? All these yellow circles? That's called axons. That's the base unit of the nerve. The signal, in this case, the sensation of pain in the knee area travels along that nerve and eventually makes it to the central nervous system, which is like the spinal cord and brain. That's when we interpret pain. Okay? Here's an important part of this. There's connective tissues around these axons in the nerve. That's shown here. This darker orange, this lighter orange, and this green. Okay? There's connective tissues around the axons. I'll tell you why that's important. There's been a lot of studies looking at different amounts of cold applied to nerves. In the range, so when you apply 10 to minus 20 degrees of Celsius, you get an interruption of the signaling in that nerve in the range of hours, 2 hours, and it comes right back. Okay? When it's minus 20 to minus 100 degrees Celsius, it's in the range of months. Okay? What this does, well, first of all, both of these amounts of cold applied to the nerves are reversible, meaning there's no permanent damage to the nerves, as long as you stay in that range of temperatures. When you get to colder temperatures, minus 140, then you get permanent damage to a nerve. Okay? The device that we're using is in this range, right here. Typically minus 60 to minus 80. It can't, and the good thing about this is, it can't get colder than this, because it's the liquid nitrogen. The liquid nitrogen is what is making the needles cold, and it just, a physical property of the liquid nitrogen is it cannot get colder than minus 80. So that keeps us in this range right here. Okay? The second degree injury to the nerve, which what it does is it temporarily blocks the axon, but not the connective tissues that I showed you in the last slide. Okay? It leaves the framework for the axons to grow back. Yes?
This may sound silly, but if you're going to put this coldness in the knee to help the nerve, what happens if you go on a hot tub?
Yes.
If you go on vacation and you're laying in the sun?
Yeah. So these treatments that's provided with this device works immediately. It disrupts that nerve. When your body, within minutes, that area that you treated with that device will get back to your body temperature, which is 20-something degrees Celsius. And then if you're out in the sun in a hot tub, you might increase the temperature around that area a few degrees, but it's not going to change what you already did to that nerve. Right? Does that make sense? So what's important about this is when you injure that axon, that base unit of the nerve, it grows back at 1 millimeter per day. Very slow, but ends up being 2 to 3 months of time to get back to where it was. Yes?
When you do this treatment, does everybody get it injected in the same spot? Everybody that would come in to have that treatment. You don't move it around. It's one spot for everybody.
Yeah, everybody gets 2 treatment lines, the ones that I mentioned before. So there's one above the knee and one on the inside part of the knee. Everybody's nerves go about the same area, but not exactly. So that's where using the ultrasound can help, because you can see the nerves. That's one. And even if some people don't use an ultrasound to identify the nerves, you treat a larger area so that you make sure you got the nerve. Okay? You treat across a bigger area, because it's going to be somewhere in that area. That's just how we're made up.
So somebody that has bone on bone, that wouldn't work for them at all?
Now, this definitely can work for bone on bone.
Pardon me?
This can work for bone on bone.
Okay.
Yes.
But do you have an area of how close being on bone to bone this treatment would still work?
This can work for people that are bone on bone. This can work for mild arthritis. This can work for knee pain that's not because of arthritis. This can work for somebody that's had a joint replacement.
What about somebody that would do that treatment and they have some form of neuropathy in their feet?
Yeah.
Would that also come in?
Yeah. So the question is, so if somebody has neuropathy, would this change how somebody responds to the treatment? You don't use this for neuropathy. It's not going to help somebody for neuropathy, but you can still use it for someone that has knee pain and has neuropathy. Does that make sense?
Yes.
Okay. Yes.
Along the neuropathy topics. What about, how does this affect the diabetic? It can be used on diabetics?
Absolutely. Yeah. So all it's doing is freezing the nerve. It's not going to affect blood sugars, what's important for diabetics at all. So this is one of the better. This is why this treatment's so nice, or it can be very nice, is because nothing's injected. It's just cold. And so you don't have the side effects that come with injecting other things.
Is it covered by insurance?
Yes. So what we've found so far is that it is covered by insurances.
What's a repeat cycle?
Yeah. So there have been studies that have, I'll get to some of the studies soon, but I'll tell you a little bit about it. There's patients that have arthritis in the knee that got treatment, typically get about 3 months of relief, up to 5 to 6 months of relief. Then you have what we did here at the hospital, which was do this treatment before surgery, and then they get surgery. That is the same idea, 3 months of relief up to 5 to 6 months of relief. You can repeat it every 3 months if you want to. So that could be an option, again, for someone that's maybe not a surgical candidate.
Does insurance limit that?
Probably. Probably, yes. I would say to be safe would be every 3 months.
Yeah.
Yeah.
Can you use it on different parts of the body?
Yes. So the device company likes to say there's a variety of other conditions that this can be used for. This is the most knee arthritis is the most well-studied one. There's also a nerve in the back of the neck that can be treated with this. That can cause pain in the neck that goes to the head, like a headache type sensation. That's the next best studied area. Not really good for hip pain, unfortunately. Those nerves are too deep. Not really good for back pain. Those nerves are too deep. There's something called trigeminal neuralgia. It's in the face area. It can be used for that. This was originally made as an alternative to Botox treatments. So people that get Botox to help with wrinkles around their face, this was originally used for that. But they found that pain got better when they used it, and then kind of went along that route. Yeah.
How about feet?
Feet. It probably can be used. I wouldn't be the one. It would have to be someone that would do it more often. I feel very confident in doing this for knees, for somebody that has knee pain, but feet probably could be used for certain conditions. I'm just not sure off the top of my head.
Stem cell therapy, they give you a % chance of effectiveness, depending on your
Yes.
condition, depending on your age, depending on your arthritis.
Yes.
What's the % chance of this effectiveness?
Yeah, so the studies have shown, in our experience so far, has been about the same. I'd say about 70% of people get better with this. It's probably 20 to 25% don't really tell the difference. And then a little bit less than that, maybe in the 1% range, where you might get a funny feeling around the knee after the treatment. But that tends to go away after a month or two. Yeah.
How would this procedure work on fingers, joints and fingers? Like if you have a trigger finger problem as you get older?
I'm not sure it's been studied.
Okay.
I'm just not sure.
Okay, thanks.
Sorry. Yeah. Anything else? Okay. All right, more on how it works. This is a nerve. These little fingers that are coming out are reaching out and getting sensation. So it can get temperature sensation, pain signals. Those signals travel down the nerve, go all the way down to here, and touch this thing that's shown here in red. This is representing the central nervous system, or the spinal cord, and eventually the brain. You apply cold to this area, and you get basically disruption of that signaling. That's what happens. This picture is not the best because you still have the connective tissue framework going all the way down here. All that's disrupted is that axon, the base unit of the nerve. Okay? The nerve regrows back at about 1 millimeter per day. That's what's shown here. Eventually making its way right back here and looking exactly like how it was at the beginning. So this is that reversible injury, meaning a non-permanent injury to the nerve. And these nerves that are treated only provide sensation to the knee. They have nothing to do with movement of the knee or anything else in the leg. It's just sensation. Risk of the treatment. During the treatment, you can feel a cold or warm sensation, a tingling, maybe a mild discomfort. We found that using the ultrasound to identify these nerves ahead of time greatly reduces all of these things. It makes it much more tolerable for patients. Following the procedure, there can be some bruising in the area. That gets better with a little bit of time. That's expected. You can get a numbness or tingling sensation, possibly some swelling around the area where the treatment is, and maybe some tenderness or pain. These are the 1 to 5% of people that have some issues with the procedure. Most of the people in the 70% range respond to this treatment. Studies. So we have a knee arthritis study. I'm actually going to skip this part. So we have, in the knee arthritis study, it showed that there's improved pain, stiffness, and function. Typically lasts 3 months. We talked about that. Possibly lasts up to 6 months. Can be used. There's a study for the pre-surgery. This is what we did here at the hospital. 45% less opioids during the first 12 weeks after surgery. Less hospital length of stay in this study, so most people were in the 1 day range instead of 2 days range after getting surgery for the knee. And then less symptoms at 6 and 12 weeks. Conclusions. So we've gone on a long voyage here, right? Talking about all kinds of things. So knee arthritis can be a debilitating condition that causes pain and functional limitations. There are many available treatments for mild to moderate arthritis and non-surgical candidates. We talked about when patients have severe arthritis where it's bone on bone, that's the time to talk to a surgeon if that's something that's appropriate for you. You can use modalities, aquatic or physical therapy, alternative treatments, topical medications, medications you take by mouth, knee injections, that includes steroids, the cartilage replacement, or the hyaluronic acid, or platelet-rich plasma, and then this newer treatment, the cryoneurolysis. Cryoneurolysis is an option for many patients to reduce pain, decrease opioid use. Thank you.